not the session you are supposed to be in and is indicated on your name tag, your room is across by the swimming pool on the other side. This room is packed. We haven't had to get the fire marshal in yet. We're busting at the seams for the room capacity here. This is obviously very important subject for a lot of people. Dr. McGowan seems to think he knows everybody here. He thinks that you're a lot of his client, a lot of his patients, and he's saying, hey, hi, how are you? Am I preaching to the choir here? I don't know. He says he recognizes a lot of faces. But after last night, we heard more at the scientific level, at the microscopic level, as to what's happening with progressive MS, where it's going. Now we have Dr. Dan McGowan letting us know a little bit more as to what is going on with progressive MS. So please welcome Dr. McGowan.
Good morning, everyone, and thank you for having me at this important conference, and thank you to the MS Society and to their sponsors in particular. I think I know most of the faces here. So I'm truly, each of you have probably heard most of what I have to say in various contacts or appointments or our interactions together. I've been asked to talk about progressive MS, and I apologize that I don't have the answer to this dilemma. What I do is primarily symptom management, rehabilitation of multiple sclerosis. And the folks that I see are folks who have had accumulated problems over time. So I don't see a lot of the early diagnosis, and I don't get involved much with the early diagnosis or even the early treatment of MS. But I see folks when they start to accumulate some difficulties, and it's those difficulties that I would like to try to review with you today and to discuss. So I do have some disclosures. I own an Australian Shepherd. I have done some talks for some of the pharmaceutical companies. And what we would like to cover today, I'll explain to you who I am, what I am. I'm a physiatrist, and I'll explain what that is. And we'll talk a bit about rehabilitation in general, and then progressive MS and our approach to dealing with the kinds of difficulties that are presented, and management of those difficulties, and then hopefully we'll have some time for discussion. There is quite a bit to cover, and if you have a handout, you'll see that at the end there's some issues on bowel condition and sexual difficulties, and I may or may not get that far. I'll try to get through the latter portion, but I may not make it quite to the end, and I'll keep an eye on the time as we go. So what is physical medicine and rehabilitation? This is a medical specialty. So people come to the clinic often and they don't know what a physiatrist is. They don't know why they're there, who are they seeing. I am a physician. I am a medical doctor. And so we go through medical school and we do our training the same as other physicians. And we do a residency program, a 5-year residency program in physical medicine and rehabilitation, the same as they do in pediatrics, internal medicine, surgery, psychiatry, all of those disciplines. And this was a specialty that sort of developed from the war years, essentially, when people were coming home with tragic injuries and disabilities. And it developed into a very specialized care of those people, so that military hospitals were formed, and then eventually veterans hospitals. And so there were physicians who took on this care full-time, and then that eventually developed into a full-time medical discipline. So the short term for physical medicine and rehabilitation, which is the college name, is physiatry. And I'm a physiatrist. I'm not a psychiatrist or a podiatrist or a physiotherapist, although I share a lot of mail with those people, I must say. It comes back and forth. And we work with our colleagues in rehabilitation, and without them, we would have difficulty doing a lot of what we do. And this is really the process to help a person reach their fullest potential, consistent with their impairment. So regardless of the diagnosis, regardless of their difficulties, and regardless of their environmental limitations and desires and life plans. And the goal is to optimize all of those things, physical, sensory, intellectual, and psychological, social functions, over time, and with the involvement of our colleagues, as I was saying. This is kind of the older nomenclature now, although we still use it a fair amount. Impairment is the term that relates to the individual, what it is about them that they have wrong. I have a broken leg. I have a spinal cord injury. I have multiple sclerosis. The disability is the term that we use when there were things that people were unable to do. I can't walk. I'm a paraplegic. I can't walk. I have MS. And the handicap is what people said you couldn't do as a result of that. I can't walk, so I probably can't be a roofer. That's the handicap. But we don't use that term anymore. What we try to talk about are still the body and its impairments, still the diagnosis, still the medical jargon. But what we try to focus on more now is what the person is able to do and what, with those abilities, can they participate in the context of all things, the person's individual choices, environmental limitations, psychosocial situations, etc. Just a few definitions. You've all heard these before. Activities of the day, activities of daily living. Those on the left are the things that primarily people sometimes struggle with in their homes if they have impairments. The things on the right, the IADLs, the instrumental activities of the day, are the things that folks might have some troubles with outside of their homes. So those are just things to keep in mind as we go forward. ADLs, IADLs. And this is our team, many of whom you've met at this conference, and with whom I work most every day. You'll see the physiatrist down on the right lower corner here, and then all of our colleagues. I hope we haven't missed anybody with this diagram. And we try to put the patient and their families in the middle. Sometimes that doesn't seem like that's the case, because as you come to clinic, you don't necessarily feel like you have the choices because of the limitations. Or perhaps those choices just won't get you to where you would rather you would like to go. Rehabilitation of MS covers many areas, many facilities, many organizations. Clearly the MS Society, the hospital programs, home care, private therapy clinics, community clinics. The university has a program to help people with exercise. And then others in and out of the Alberta Health, Optimus, CAR, Living Well, Care West, all have various programs with whom I have some interaction as well as patients come and go. This slide, I think most of you have seen before in some version of another, just to outline the different courses of multiple sclerosis, relapsing remitting being the most common, and then secondary progressive and primary progressive, which for me in my clinic, I really can't distinguish, or I don't make the distinction when I see folks with their individual difficulties. So often when I tell people, and some of you have heard this before, is that I almost don't necessarily go back too far in the chart to find out what the diagnosis is, what the progression is. I basically take a snapshot of how things are that day, and with some background knowledge, try to predict what we might have to focus on as time goes forward. Just a slide to show that relapsing remitting is the most common presentation, and roughly 80 to 85% of people with relapsing remitting will sort of have a progressive course within about 10 years or so. And so the numbers of early diagnosis are quite high, but eventually the numbers of people with MS are in a progressive stage as time passes. Those numbers are higher. So the natural history, people start more often with a relapsing remitting as compared to only 15% with a primary progressive at diagnosis. And then over time, as I say, the number sort of switches over to a higher percentage of progressive types of injuries or conditions. So this print is small, I apologize. It's really just from an article to review what about progressive, how they differ. Are there any differences in the progression of folks with secondary progressive or primary progressive? As you can see, the average age of presentation for primary is a little bit older than those with relapsing remitting, usually into the 40s or 50s, about 10 years older than those with relapsing remitting. Relapsing remitting is more prominently a female entity. More often it's the higher percentage of females are diagnosed, and males develop primary progressive MS as frequently as females when they're first diagnosed. And the rate of progression varies among patients with primary progressive. Sometimes younger patients and males who are diagnosed with primary progressive have a higher risk of more rapid progression over time. What I see is this insidious onset of symptoms, most commonly difficulties with walking. And so very frequently folks may have been to various physicians with that complaint. And may not necessarily have had a first diagnosis of MS. They may have been seen for a weak ankle or a weak knee. Often people come in with a knee brace having seen an orthopedic surgeon first, for instance. Some studies note that up to 50% of patients sort of fall into this category, and certainly that many may have weakness in their legs by the time of diagnosis. There is a varying rate of progression among all patients with progressive illness. About 25% need cane within about 7 years, 50 within about 13 years, and 15% perhaps a wheelchair within 20 years. And yet there are as many as 30% who are still partially ambulatory, even after 30 years of their diagnosis. I don't know that I necessarily need to dwell on these facts, because you folks are demonstrative of that statistic. My point really is that once progression occurs, the rate of progression is quite similar from secondary progressive to primary progressive MS, and that's the population that I deal with mostly in the clinic. So the typical onset of a spastic paraparesis, meaning weakness of the legs, occurring. You may catch a toe, you may have some tripping or stumbling. Initially, perhaps attributed to fatigue or shoe issues, or, as I say, orthopedic problems. And then perhaps they're aggravated by heat, infection, overexertion. Stiffness, pain, cramping in the legs may occur. That's kind of an early onset of spasticity. And it's common for weakness and spasticity to be asymmetric. It's not like a spinal cord injury where more often we see sort of individual levels of difficulties depending on their level of spine problems. And then there can be other problems with ataxia, which is imbalance, or troubles with their vision, or troubles with their speech. And again, my point with this wordy slide is just to say that the management is essentially identical for these symptoms, for these kinds of progressive entities that we see. And we'll talk about those as we go forward here. So as a physiatrist, people in physical medicine, rehabilitation, along with our rehabilitation colleagues, we essentially focus on these kinds of symptoms, as opposed to early diagnosis, disease-modifying medications, and those sorts of things. And I've listed all the areas that I sometimes try to touch on when I see people in the clinic. You can imagine that that may be a difficult thing to do, cover all systems and all complaints in an hour, first appointment or half-hour review appointment. Occasionally we have to bring people back and talk about the things you can. This is not meant to be read, it's just to outline our approach to the EDSS, the Extended Disability Status Scale, which we use in the clinic to monitor change over time. Each of these little blocks represents a portion of the neurologic exam, and there are some people in this room for whom that's the only reason I see them. When we're following them in clinical trials, I may be a blinded observer, and you come in and we joke about how we can't talk about anything more than the weather. My job is to do the exam, and this is the exam that I do, the EDSS, and we come up with a number. And all of you have heard about these numbers, where on the EDSS score, 0 is a normal exam, and 10, unfortunately, is death from multiple sclerosis injuries. I only put this here to sort of outline the progression over time, so that, as I say, the folks that I rarely see are those with a lower EDSS. My work happens from about 3 and beyond. And just to outline another point, this is a paper that goes over the natural history of multiple sclerosis by some Canadian colleagues, neurologists, and others. And really my point was they use slightly different terminology, but for folks even with a very high EDSS, the time that they take to go from an EDSS of 8 when they're in a wheelchair until they get to an EDSS of 10 can be a very long time. It can be sort of 20 years. So that's our work. That's the portion of the population for whom I focus a lot of my attention. Those folks have difficulties that will last not just a couple of months or a couple of years, but for a very long period of time. So when we're dealing with pain, spasticity, bladder bowel issues, there's no short-term fix. We have to talk about how we're going to manage these things for a long period of time. These are interesting slides from places in Europe for their MS societies that are meant to sort of be a little bit in your face as far as the awareness of MS is concerned. So the area that I spend a lot of time on in the clinic is mobility, as do our rehabilitation colleagues. Problems with ambulation due to weakness and spasticity are among the most common and most feared by the population. And as I say, I'm preaching to the converted. You folks know this probably as well or better than I. And a good portion of folks with progressive disease have these difficulties. This is the EDSS score listed in just line form, and I've sort of divided it into 3 groups. And you'll see here that this number from number 1 up to number 5 are those who are able to walk without assistance. The numbers in the middle require some assistance, and then those above use some form of wheeled mobility. I'm going to just talk about these individually. You'll see that for somebody with an EDSS of 5.5, they are able to walk unassisted or without rest for up to about 100 meters or so. Now that might mean that they still have some difficulties. They might still have weakness, they might still have spasticity, and quite frequently they will develop weakness. It is curious in MS that weakness develops in a term we use in medicine called the in a pyramidal fashion. That has to do with the nervous system and its neurologic tracts. So that weakness very frequently occurs in the muscles that you use to pull your foot away from the ground. So to pull it against gravity. And curiously, the muscles that you use to push down stay quite well preserved as far as the strength is concerned. So more often than not, folks have troubles bringing their foot up, bending their knee, and lifting up their hip, or bending their knee higher, lifting their leg. And they still are able to push down against the floor and stand up a little bit more easily. That's a curiosity of weakness in MS. So very frequently, if a person has troubles lifting their foot off the ground, then we often will talk about an ankle foot orthosis, or an AFO. And this is meant to help with 2 things. One is to help prevent the foot from dropping down when you lift it off the ground. The other is to prevent the knee from snapping back when you're standing on the foot plate. So you can imagine if a person is standing on this foot plate, their knee is going to have to push against this upright to get to go back into extension. So just to go back to that point about some people having first seen other physicians and maybe getting a knee brace, which is fine on occasion, but sometimes the concern is not necessarily their knee, it's because the foot drops down and as a result the knee snaps back. So sometimes that's why we spend a lot of time talking about these devices. They don't necessarily change the walking speed. The time 25-foot walk in some studies didn't really show much significant change, although for some it can do. And it didn't necessarily do a lot to help with dynamic balance. But we do think that it helps to reduce the energy required to go the same distance otherwise. This is a very old brace. This is called the Clensac brace that we don't see very much at all anymore. Then we can brace other things as well. We can go above the knee. But these things are quite heavy. These are the older varieties. These are the new materials. But they're very, very heavy, very cumbersome. They tear up your clothing if you're wearing them all day long. And in my opinion, there's not a lot of role in this population for using these kinds of devices. They're very difficult to lift if you already have that weakness in the hip These are different varieties of ankle braces, but they're often used for other kinds of conditions. People who don't have troubles lifting their foot, but actually have troubles pushing their foot down. So there are some paraplegic patients that I would sometimes prescribe this kind of brace for. There are other varieties of the same thing that you can buy off the shelf. These are commercial products that do the same thing, but they don't require custom manufacturing. These other braces, these ones up here, require that you go to an orthotist, put a cast on, take the cast off. They put the cast together, fill it up with plaster, and it becomes a mold of your leg. So these varieties are ones that can be purchased off the shelf, and they're made of light carbon fiber products. So they're not necessarily as sturdy, they're quite a bit more flexible, so they may not give the same kinds of support, but they're meant to do the same sort of thing, keep the foot from dropping down, and perhaps this one would resist the knee from going back a little bit. Sometimes people that I see don't want these devices, and I must say I can't blame them. They're expensive, they're bulky, they're ugly, they're hot, they're hard to get in your shoes. You might have to take the insole out of your shoes. You might have to buy a shoe size larger to get these things in on occasion. So I know these things, mostly because you folks have told us that that's the problem with them. So they're not easily prescribed, and they're not an easy thing to take on, or I just don't do it nilly-willy like a Tylenol and kind of thing. Sometimes we can compromise, and there are some other commercial products that will help to a degree, but not necessarily to the same degree that those other braces will do. So these braces will help prevent the foot from going inside or outside, inversion. So you're less apt to fall on a sprained ankle with these kinds of things. And if you lace up these other varieties inside your shoe or a high top boot, then they sometimes can provide a degree of support that these other braces can do as well. I'm not a big fan of these toe straps. I really don't like them very much at all. These things slide around, and I don't like them very much. Some of you may have heard of the Walk-Aid. Somebody might be wearing a Walk-Aid in this room right now. This is the device that's University of Alberta invention, actually, in Edmonton. And this is the device that has the electrodes that goes over the nerve just on the outside of the knee. That nerve is very much like your funny bone. If you whack your funny bone, you get that tingling sensation in your hand. The same is true with that nerve on just outside the fibula, the bone of the lower leg. So those electrodes go over that nerve, and then the Walk-Aid has the electrical stimulator and the gyro to measure the angle of your foot, so that when your foot goes back in your stance, it fires and your foot comes up, and when your foot swings forward, it releases the stimulus and your foot goes down, so that you get sort of an electrical replacement of the brace that you've had before. It's not for everybody, unfortunately, and it sometimes is a bit tough to decide for whom it's best. In my opinion, I think folks have to have a fairly good velocity of gait. They have to be able to move fairly quickly to take advantage of these devices. And the least amount of spasticity is better. If you have high spasticity in your leg, then sometimes just the shocking can stimulate the tone on its own and cause your foot to shoot up. And it does give you a shock with each step, and some people can't tolerate that necessarily. So again, it's not the be-all and the end-all. They're very expensive, so they just can't be for everybody, unfortunately. And then who knows where we're going with these devices, right? These are exoskeletons. There's a gentleman who's talking at the Foothills Hospital about exoskeleton device for not just MS or spinal cord injury, but as his area of research. And then we've heard of body weight support systems, being on a treadmill to do some walking. That's a very labor-intensive task for therapists because, it takes more than 3 or 4 people sometimes to support the body and move the feet over the long time of therapy sessions. So people are actually developing commercially made products. This is called the Locomat, it says right there. So these are devices that, who knows, we may see over time. So then there's the next group. The group who require some device to help them walk, some device in their hands to help them walk. And unfortunately, these are the choices. Not very sexy, not very pretty. I see this all the time. You give a young kid a who has a sprained ankle, a pair of crutches, and suddenly they, everything about their whole body collapses. That's a terrible posture for crutches, and for that reason, I'm not a big fan of just the regular kind. The lap strand, the old Canadian crutches, are actually underutilized in my opinion. They're very maneuverable and stable, and depending on where the cuff is, you can even let go of the handle and put your hand on a doorknob, for instance, and turn the knob without letting go of the crutch completely. These things are personal choices. It does take a bit of an act to get used to them. So do the canes. Even these devices, although they look simple to work, they do take a bit of an act to use. So rarely would I prescribe them, and just say, go get one, without necessarily asking the person to have an initial session with the therapist and then maybe a follow-up session with the physical therapist to review the gait. Some people, as you know, would rather use walking sticks or hiking poles. Again, a personal choice, and these are very helpful to provide stability. And then there are the walkers. So the purpose of all of these is to provide a broader base of support. If you stand on one foot, clearly you're very unstable, and you look more like this diagram. All of your weight is distributed over a very small surface area. If you stand with your feet apart, or if you put a cane out on the side, then suddenly your base of support is quite a bit wider. All of the area underneath your cane and your feet is the base of support on which you walk. If you use a walker, as aesthetically pleasing as these are sometimes, they provide a very wide base of support. So you're going from looking like this to looking like this, and that's the purpose of these devices, is to provide you with a more stable base on which to walk for longer distances. We've had a few people come in Segways. You may have seen them, perhaps at some of these meetings. Unfortunately, I don't think the business did as well as they had hoped to do, but certainly people who have surprisingly a high difficulty with mobility are able to operate these devices, but again, they're very expensive. And then there are those who require some sort of wheeled mobility. Many are here. And there's various kinds of wheelchairs and powered wheelchairs. And then, as you know, there are all the hoops you have to go through to get these devices. Particularly if you want to take advantage of Alberta health coverage, Alberta ADL coverage, or other ACE coverage, or those sorts of things. You need an authorized person to go through those steps with you to follow the rules. Sometimes you see these devices on the internet and you think, wow, that would be cool. You'd like to ride on one of those for a long distance, or maybe something like that. So there's no secret to these, although we do spend a lot of time sometimes with patients trying to get the right fit. Some of you may remember our old friend who used to get around everywhere in a chair, operated by her head, using a chin control to change the ears and the direction of the chair. She had her visual display here. She had her phone with a Bluetooth connection. She could receive calls, but she couldn't call out. She had her CD player and her earphones on. She had her water bottle. She was set for the day when she got up in these chairs. And this is what's called the tilt and space chair, so that if you're sitting all day in the chair, you don't recline like you would at home. So at home, when you recline, your chair goes like this, which unfortunately sometimes means you can slide a little bit, and that's when you get shearing forces on your bum, and simply perhaps more risk of skin breakdown. So these devices are meant to tip, maintaining that 90 degrees so that the weight goes from your bottom onto more of your bottom back of the backside and the lower back as well. Again, very expensive devices. And, sometimes modifications can be done beyond our imagination. Folks certainly like to be able to stand vertical, and that's particularly true of our young spinal cord injury population in particular. There are many different kinds of standing frames that sometimes people will take advantage of. And if you were to go online, you would see many versions of these kinds of devices. for that population, for the spine population, we actually have to be sure that their bone density is sufficient to tolerate these forces, because you sort of push up on your bottom against your knees to get to the standing position. Fortunately, that's not as much an issue for the MS population, but sometimes there are things that prohibit that. Perhaps spasticity or joint contractures don't make it necessarily an easy task, but there are folks who prefer to do this. These kinds of passive pedaling machines, this is happens to be a Motomed variety. There are many more, and so you can put your feet in the pedals and the device will pedal for you, or you can turn it down and assist with the pedaling, both for the arms and for the legs. And again, particularly our spinal cord injury population really like these devices as far as providing exercise. So to do with mobility as well, I think probably everybody has heard maybe a little bit about Fampira or Dalfampridine. And our Biogen colleagues are the company that follow this medication now. This was approved in the US, I guess maybe 2 years ago, almost 3 years ago, a lot now. And then early this year in Canada. And it's a medication that has demonstrated some increase in walking speed in people with MS. It says here improves their walking. I think that's maybe a bit of a broad statement, but certainly in the studies it was shown to increase walking speed. It's a chemical that's been around for a very long time, and it was actually studied even in the early 90s, late 80s in the spinal cord population. So it's gone through various trials with various companies over the long haul. And these are the two studies that allowed it to be approved. And basically what it showed is that for a portion of the MS population, about 35% in this study, it showed an improvement in walking speed of about 25%. In the second trial, it showed about the same number, 40%. This one was 35. So I tell patients between 35 and 40, it's a little bit higher. For this medication, about 35 to 40% of patients, it showed about a 25% increase in walking speed. And that's the same number that they had in the previous time. Showed a little bit of improvement in muscle strength, a little bit of improvement in spasticity. But I think we'll find over time whether or not that pans out. There may be other trials that are happening that will look at these things a little bit more specifically. But for the time being, what this medication has been approved for is to increase walking speed. Now, whether you extrapolate from that increase in strength, increase in energy, increase in balance, I think you can make up your own mind. And but we can't necessarily say that because that's not yet what studies have shown. It showed an increase in walking speed. So it's a medication that is taken twice a day in a sustained tablet. And it's for those folks with an EDS score of 3.5 to 7. So those who are lower than 3.5 are probably too good that they wouldn't get much benefit out of it. Those with 3.5 are the ones that I showed you who might require an ankle brace but not get a cane. Right up to the folks who would require a walker even to go 20 meters. So 20 meters is what, 60 feet or so. So those are the folks who qualify for this medication. If you don't stand and you don't walk, unfortunately yet, it's not approved for that population. And it should be prescribed by experienced physicians. So for the moment, I think the MS clinic has the physicians with the most experience with this drug. Family docs wouldn't yet know the parameters of this drug, and over time we all get a feel for our different kinds of medications. And we're just at the stage of prescribing this where we're starting to get that feel of for whom it would benefit and those sorts of things. So it shouldn't be prescribed in those who have had a sensitivity to this ingredient, the fampridine, or anybody who's taking a compounded form. Some of the pharmacies would have just made this up on their own in the past. Can't really give it to anybody with renal difficulties, and for that reason we do some blood work before, depending on when it was last done. If there's any history of seizure, it can't be prescribed. And then there are some other medications which might actually increase its level in your blood as well, so we have to keep an eye on that. And those are the kinds of things that we're getting a feel for as we go further in time. So this medication is being prescribed now. It is quite expensive, but there is a program that if we help you apply for, the pharmaceutical company will cover the first month trial. But if that's to be considered, then what I usually ask is that patients find out if they have their coverage from their private insurers or others. I don't have too much more to say about that. Maybe I can answer some questions about it a little later. Also to do with mobility is spasticity. I see a lot of spasticity in this clinic. And spasticity is really just the increase in muscle tone that we see, an increase in reflexes. So muscle tone is the sensation of resistance you feel when you try to put a joint through range of motion. So it might be mild, you might feel just a catch, or it might be severe. You might not be able to bend the joint. It is so stiff with spasticity. And it doesn't necessarily cover involuntary spasms or clonus, which is that repeated tapping of your toe that can happen at times. But I must say we do use those terms all interchangeably, and I consider them all the same as far as treating spasticity is concerned. Spasticity in neurology is part of the upper motor neuron syndrome. So with spasticity comes that increase in resistance, the spasms, increased flexion, reflexes. These are all part of the upper motor neuron with syndrome with spasticity. But also with it comes weakness, incoordination, and fatigue. So sometimes that's a notion that's hard for us to sort of conceptualize. There are folks who feel that if we can just get rid of their spasticity, they'll be able to, stand and walk normally. But we know that for everybody who has spasm, they also have weakness, and we can't treat the weakness the same way as we treat spasticity. In fact, we have to be very careful not to make it worse on occasion. The kinds of things that spasticity interferes with is, it can cause pain, and then pain can cause worsening spasm, can cause sleep disturbances, fatigue from the high energies, expenditure of having contraction all the time. Certainly can impair mobility. The clonus that I say can sometimes interfere with walking and standing. And then sometimes you get this scissoring of the legs as they come together when people try to stand or walk. Certainly interferes with activities of the day and IADLs as well. So it can happen in just about any joint. This is sort of a deformity we see more often in people with brain injury and stroke, but certainly those with MS can have a similar kind of difficulty. Or a clenched fist, or legs that are tight together. And so that it's hard for perineal hygiene, the middle body hygiene, and sexual function, and also there are troubles with shearing and positioning patients, risk of contractures so that the joint gets in that position and you can't get it out of that position. So what do we do about these? This is a kind of a busy slide, but it talks about widespread increase in tone, for which we might use some medications, or local tone, where one joint might be more prominently affected. In those folks, we have some strategies, including botulinum toxin, and for these other ones, we have some things I'll talk about. Range of motion, stretching, massage. You have to be careful for some, if their bone density is low, not to be overly aggressive with stretching and massage. But fortunately, we don't see many fractures as a result of therapy in the MS population. We do see it in this time population now. Heat and cold, electrostimulation, these things, as you know, sometimes provide relief, but often it's very short-lived. It doesn't last very long, maybe an hour or two, or maybe for the day. But if you can't get it every day, then it's sometimes not thought to be that useful. And certainly time-intensive for therapists, expensive for patients. These medications you'll probably recognize. Baclofen is still the first drug of choice for people who have spasticity. Tizanidine or Xanaflex is another that we use, and then some others, including Valium and Neurontin and other medications that sometimes are better at treating pain, sometimes are better at treating spasticity, or if you have painful spasticity, then we might choose one medication over another. And sort of that's that feel that sometimes that we think we have, we hope we have, that we might not yet have for a drug like Vampira, quite yet. But as time passes, I'm sure we will. And then there are other things to consider. Botulinum toxin, Botox, myoblock, there's a couple out there now that we can use. Injection with phenol into the nerves, we don't do much anymore. And then the intrathecal baclofen pump program, I run with the folks at the MS clinic as well, and we'll talk a bit about that. These are just patients that we injected Botox into legs that were difficult to get apart. And although it doesn't seem overly impressive with regard to range of motion is concerned, certainly the improvement is enough to help with care, personal care. Same is true with the knee that was very flexible. It was even difficult even to get the syringe in close enough to do the muscle injection. But we were able to get at least enough change that we could have this person sitting up more comfortably. And eventually the heel sores went away as well. This is a baclofen pump. It looks like a hockey puck sitting on the front side of the person's abdomen. And basically it is. It's a big metal disc in which is the baclofen, and then from which comes a catheter that wraps around the back through the side tissues and then into the spine. And the top of the catheter, you'll have to take my word for it, is right there. And it delivers liquid baclofen into the spine 24 hours a day. So for some folks, if their spasticity is high and they don't seem to be able to get control with medication, or they can't tolerate the higher doses of medication, then we'll occasionally think of putting in a baclofen pump. These things then mean that you have to come to the clinic about every 4 to 6 months for a refill. And the nurses do that by putting a needle just through the skin into the pump and filling it up. And then they check it with a computer programmer, and then away they go again. So in the clinic we have, I'm not sure the numbers for people with MS specifically, but it's probably 10 or 12 or so who have these devices in right now. Not big numbers, but some people elect to go ahead with this device. And then sometimes for spasticity, just to finish our mobility section, we occasionally don't make much progress by using Botox or medications or stretching. And occasionally we will have folks go to one of our orthopedic spine, or orthopedic colleagues rather, and they will do what's called a tendon lengthening procedure. So this cartoon is meant to show that this person has difficulty getting their heel to the floor, and if you make a sort of a cut in it like you do a ribbon on both sides and pull the ribbon tight, it'll kind of distort, then the heel will, be able to get onto the ground. So sometimes we do that for even just foot positioning on wheelchairs. We can do it for other joints if they're contracted or flexed. And it means a small operation, but they work quite well sometimes to help relieve the discomfort of these positions. So if mobility issues are the things that I spend a lot of time on, probably bladder, bowel, and sexual function is the next area that I spend most of my time on in the MS clinic. And really, I just want to go through this quickly. These are just cartoons of the male and female anatomy. Really, I don't need to go over it any more than to say that for males, if they're using catheters, they have to go in not just from the surface, but through the penis and in through the prostate and then into the bladder. The female anatomy is quite a bit shorter, which sometimes explains why there's maybe a little bit more propensity for bladder infection and things sometimes there. But you can see that the bladder is just a reservoir in the lower pelvis, and you can imagine that it can get quite big. If you put a liter of fluid in there, it can take up a lot of space in the lower abdomen. There's the bladder sitting right there in the pelvis. The ureter is going up to the kidneys on either side. So we spend a lot of time thinking about the anatomy and what problems might do to the anatomy over a long period of time. Basically, when I think of folks with troubles, we think about whether or not they have a difficulty with failure to store their urine, meaning they seem to be going all the time and they just can't seem to store, or whether they have a failure to empty. They have difficulties getting rid of their urine. Sometimes it's very difficult to distinguish the two. If you are unable to store, that implies that you can't hold any urine and it comes out. If you have a failure to empty, at some point your bladder is going to get full, and then it's going to start kicking out small volumes of urine. And at that point, it's very difficult to distinguish one from the other. So often we will have folks go for an ultrasound or see the nurse in the clinic with the bladder scan, and we will do what's called a post-void residual urine. We'll measure how much is left over after they go, If it's low, then the person probably has a failure to store, a hyperreflexic bladder. If they have a high volume, then they have a failure to empty. So either the bladder is lax, or the muscles that prevent the urine from coming out are overly tight. And then we fashion our treatments depending on which of these we see, or sometimes it's not quite as clear as this even, and it's a little bit tougher to treat. We can do some other investigations, urodynamic studies. As I say, we can do a urinalysis, post-void residual, or we may do some blood work and an ultrasound, and if need be, we can go on to such things as cystoscopy with the urology colleagues, or a CT scan of the tracts. And in our management, we want to try to allow the person to have, to remain continent and to empty, hopefully not more than every 3 or 4 hours, minimize the inconvenience of that, improve sleep, avoid recurrent infection, prevent renal deterioration, prevent scarring of the kidneys. So those are all the things I'm thinking about when I say to a person, gosh, we better check your residual. We might have to talk about catheterization of the bladder. So it's not just to make life hard, it's to try to prevent these things from happening if we can. Sometimes we have great luck, other times maybe not so much. And there are different approaches to dealing with the bladder. We can do just some behavioral things. Sometimes just going to the washroom every 3 or 4 hours with your watch alarm is sufficient. There are some other maneuvers, primarily in the spine population, which work a little bit better for them, where they can actually tap on their sort of pubic area, and that will cause a bit of a reflexive contraction, and then they can have some emptying of their bladder. But more often we rely on various kinds of medication and urine collection devices. I'll get to the medications in a moment, but you folks may recognize these, unfortunately. But this is a catheter into the female bladder, catheter into the male bladder. You can see the difference in length, and these are anchored with a bulb. There's the bulb there with the catheter, and then you inflate it up several cc's. The color on this is not great, unfortunately. For the men, there's a condom drainage, which I often think some people should take more advantage of, just as it can provide convenience. Unfortunately, there's not a female equivalent. There have been attempts over time, but they don't really work very well, unfortunately. And then you can consider a suprapubic catheter if there are troubles with the lower end or for other reasons in the long term. But these are what are available to us, and this is kind of our approach over time. There are different medications we can use to try to help relax the bladder. So if you are emptying, but you're having to go all of the time, these medications will work quite well for you in some instances. If you're storing your urine and you can't empty, then these things can actually make you a little bit worse. So that's the importance of doing a post-void residual measurement. If I took these medications right now, I'd have to find somebody who has a catheter and borrow it, because they would make me stop going. So we have to be very careful with these sometimes. These are the medications, along with some of the antispasm medications, that make your mouth really dry. And sometimes people can't tolerate that as a side effect. They're not inexpensive. They sometimes don't do even what we hope that they would do, but these are the tools we have available to try. Botulinum toxin, Botox, or the others now, is considered essentially a second-line treatment of people who have overactive bladders. And perhaps there's many of you here who see our colleagues in urology at the Rockley Hospital to have Botox injection into their bladders, not just for spinal cord injury patients, but for people who have what we call neurogenic bladders. People whose bladders are not working because of their neurologic disease. MS is one of those. ALS is another of those. Different spinal cord injuries, spinal tumor, those sorts of things. So what the urologist does is they take their cystoscope and they go in and they use a needle at the end of that, and they inject the bladder over sort of a grade. They kind of, in their mind's eye, look at it as a dome, and then they just kind of go like a graph all the way through with the Botox. And that allows the bladder to relax from a contracted position to a more dilated position. So we're trying to do with Botox what we do with these medications, but if these don't work, then what we often consider is bladder Botox. This has worked very well for some folks. unfortunately, it's time limited. It only lasts about maybe 6 months, 9 months for some. If we inject Botox into the muscles, like I was telling you, unfortunately, the benefit only lasts about 3 months, and so we have to repeat the injections periodically. So it's 11:45, or 11:35 rather. These two sections are on bowel management and sexual function. Bowel management, unfortunately, is as individual as there are people who have difficulties with their bowels. So there's really no one recipe. Many of you may have heard the spiel for using stool softeners, medication stimulants. Sometimes we have to resort to suppositories, sometimes small enemas. We try to focus on adaptations, making it comfortable for the person to have these things done to them. Occasionally we have to do it in bed. And on occasion we actually go to such measures as considering a colostomy for some folks who have been dealing with their bowels so long over time that it takes up much of their day. And there are folks who come to clinic who say, I spend 3 half days a week on the toilet. All of Monday morning, all of Wednesday morning, all of Friday morning. For those folks, having done that for a while, they go on, and as disfiguring as this seems, or as difficult as it is for many of us to conceptualize having this done, I will tell you that folks who have been on to have this done have very few regrets. Why didn't I do it 5 years ago? So it's not for everybody, of course, but certainly bowel problems related to MS and other neurologic conditions are very difficult to deal with and to change. It can take several weeks for a new time to be developed for folks to change their bowel routine. It's not just, this medication didn't work today, I'm never taking it again. Sometimes it takes a long time to get through bowel difficulties. Sexual function, I'm not going to spend much time on it. It used to be that we didn't have very many options to treat male erectile dysfunction. And now the treatments are all those that you see advertised on television, and they work quite well. Sometimes we have to resort to other strategies, but more often than not, these kinds of things work. And what we focus on mostly then would be, for both males and females, managing pain, managing spasticity, managing position in bed, managing mobility. That's our approach to sexual function, as opposed to, writing a prescription for Viagra, which can be used for female problems. So, I don't have the answer for progressive multiple sclerosis. I don't think anybody does, and unfortunately that's very disappointing for people when you come to the clinic. There are 1 or 2 trials that are happening, but again, the admission criteria sometimes is a little bit restrictive, and it's probably best to go through the clinic nurses for that kind of information. But it is disappointing for everybody not to have those same kinds of things that are available to relapsing remitters. But as I say, I spend my time trying to deal not so much with that, but with things that are available, making people aware. And very frequently you'll sit with me and look on the computer, and we'll go through all of these things and decide what might be more appropriate for you. That's how we spend our time. And certainly couldn't do it without the rehabilitation teams in its various forms, all of the various agencies in town that contribute to the care of not just people with MS, but those with various impairments, particularly the MS Society for you folks, and many others. So I think we have some time for questions, if that's okay. And I'll start, sure.
Sure. Just interested about the Vampira. So I take
Yes.
back things. I have spasticity on legs. I use canes for smaller distances than
Yes.
scooter with gondolas. So the Vampira you talked about increases people's walking speed.
Yes.
So would you use it in combination with Baclofen to deal with your spasticity? How does it, what's the action that it works on?
So the question is, would we use Vampira in association with other medications? And the short answer is yes. We would use it. There are 1 or 2 medications about which I have some concern, but we would talk about that on an individual basis. But most of the anti-spasticity medications, certainly the disease-modifying medications, the Rebif and Copax, those things we would consider as well. there really aren't too many things that we would exclude at this point unless we thought that they were contributing to slowing down your kidney functions. And they mention only a few there, which are not commonly used, to be honest. So, if a person has, we think, normal kidney functions, no history of seizures, they're able to walk 25 feet, then we will consider the prescription for the
So how would that, I guess, how does that add to the back, like, why would you add?
So baclofen is an anti-spasticity medication, and if you have spasticity that's maybe slowing your gait down a little bit, then baclofen might help with that. Might help with that. Fampira is meant to help potentiate or improve the signals through the nerves that are partially demyelinated. So it actually helps to improve conduction along the nerves. I'm sorry I didn't mention that as I went through, but I could have made this a talk about Fampira, but I wanted to cover some other things as well. But that's what Fampira is meant to do. So it actually has a completely different action, basically, than any other medication we've had available to us ever before. But again, there's, I don't want to overstate it. It works in a percentage of patients, and it helps improve, walking speed and so on. Yes.
On the back of the pump, just some criteria as to when you might start using it. Do you have an EDSS scale?
So the question is regarding the baclofen pump and when we might start using it. The baclofen pump technology is quite energy consuming, resource consuming. It takes a lot of us to run that program. The many nurses in the clinic, my time, the neurosurgeons' time. So we don't include all comers, unfortunately. There may be some folks who are walking and using various kinds of antispasticity medications. And for that group, we try to continue things as is. There are some, however, who get to very high doses of baclofen because of severe spasticity, or baclofen, tizanidine, many other drugs at the same time. And then clearly they start to have issues with alertness, cognition, weakness, those sorts of things. If their spasticity is still high, despite those medications and with those side effects, that's probably the person that we would think would be the best candidate for a baclofen. So it wouldn't matter on the, just to get to your specific question, it wouldn't necessarily matter on the EDSS, although most folks who have a pump have quite a high EDSS, from about 7 and above.
So if they're still walking?
There are occasionally some who walk, but I must say, we will not necessarily put the pump in to regain mobility or to make the person walk. If that's the objective, we probably aren't going to go there. We cannot, as I say, with spasticity comes weakness and coordination. The pump doesn't fix weakness and coordination, those sorts of things. It will get rid of the spasticity. And there are occasionally a person who, with that kind of reduction in tone, can get to standing and walking. More often than not, we're worried that we can't dial the pump down low enough to give them the amount of spasticity they need to stand, but be comfortable. So there's always a very fine balance. So for people who use their tone to stand, we can take that tone away and make them not stand with the baclofen pump. And sometimes, once it's in, we can't necessarily be absolutely sure that we can dial it down sufficiently to get people to stand. So if we can get along with all these other things, medications, Botox, bracing, walking aids, we would rather go that route before we put a pump in. And the pump comes with its own set of problems, so that's another reason to consider.
The patient that is on max doses of your antispastic medication orally,
Yes.
still trying to walk, and obviously the spasticity is the major issue. Would they be at baclofen pump?
Possibly. But again, if they're walking and their spasticity is a major issue, they're almost certainly using some of their spasticity to help maintain their ability to stand and walk. And if we get rid of their spasticity, we still might take away their ability to stand and walk. So that's the gray zone with which we have difficulties. I will admit, they're not an easy choice, and sometimes we err on the right side, maybe some on the wrong side. It's tough when we overdo it and take their ability to stand and walk. So we're a bit gun shy in that regard. For those beyond, we would consider baclofen.
So it's more a comfort measure.
Yes, for sure. It is that. It's the comment is more, it's more of a comfort measure. It truly is a treatment of spasticity, severe spasticity. Yes?
What about dizziness? Is there any drug that can help that at the time?
The question is there any drug that helps for dizziness? That's a really tough question. And no, there are not many that are specific for dizziness. There are some that we use for the dizziness you get when you're not feeling very well, you know, like Gravol and Xyler, some of the other ones like those. But there are none that are specifically for ataxia or vertigo or those sorts of things.
That's what's wrong with me.
It is tough. The other, and I will say now, the other symptom that is most difficult for us to treat is tremor. There are no medication. Those two symptoms, tremor, dizziness, difficulties with the eyes, actually come from more often from a different part of the brain, from the cerebellum as opposed to the cerebrum. So the cerebellum sits down lower in the back, and along with its connections, when involved,